Hey guys, this is Joel here. This is a short overview of what I'm going to be covering in this lecture. You can click on any one of these links to skip to that point in the lecture. Also remember, you can click in the upper right hand corner, which will take you to the index, and there I have links to every point in the video as well. Alright, let's get started. Well, let's jump right into sensitivity and specificity. They are statistical measures of the performance of a test. And in the clinic, you are going to need to know these concepts well enough that you can talk about them conversationally without having to stop and think about it. And the reason is because we use them actually pretty often to discuss kind of what we're thinking when we order a lab or how we interpret some data that we're looking at. They are high-yield topics. Sensitivity is a test's ability to identify a condition correctly, and specificity is a test's ability to exclude a condition correctly. So what does that mean? Well, let me tell it to you the way it was taught to me. And I kind of learned it through a story kind of like this one. The house on the right. This is the first house Matt gets when Matt first goes off to college. It's a nice little house. Problem is, it's in a bad neighborhood. And young Matt has one prized possession. That's his car. He loves his car. It's a sweet pimped out ride. So he's a little bit nervous about parking it on the street. So he goes to the store and he buys an alarm for his car. And as he's installing it, he notices that there's a dial that you can spin from 0 to 100%, and it's got the word sensitivity at the top. Well, Matt thinks to himself, geez, I definitely don't want my car stolen. I am going to turn the sensitivity all the way up to 100% because I want to know if this car is being tampered with at all. Well, about half an hour after installing the alarm, Matt goes inside and, wouldn't you know it, a motorcycle drives by and it sets the alarm off. It's so frustrating. Comes out, turns the sensitivity down just a little bit, and goes back inside. About a half an hour after that, again, another motorcycle drives by, and then again, the alarm goes off. So Matt goes back outside, now even more frustrated, and he turns the sensitivity way down. Goes back inside, keeps unpacking. Then he notices out his window, that same motorcycle drives by. This time that motorcycle does a wheelie right past his car. It's really loud, and the car doesn't go off. Perfect. Matt is very happy with his settings on his alarm. Well, at about midnight, the motorcycle rider, now dressed in different clothes, comes by to check out Matt's car. He jiggles the doors, pries at the locks, shakes the windows, finally gets into the car, and steals it. So what's the problem here? Well, the problem here is that Matt left the sensitivity too low to prevent a theft. And he did that because he was tired of the alarm going off for false positives, or just for motorcycles driving by. So here's the question, where do you set the sensitivity? You want it to be sensitive enough to catch a thief, but not so sensitive that it's going off every half an hour when a motorcycle drives by. So maybe it would have made more sense to Matt if the dial, instead of saying just sensitivity, would have been expanded and also shown specificity, and also somehow demonstrated that as one goes up, the other goes down. So again, let's look at what sensitivity means. Sensitivity is the test's ability, or in this case, the alarm's ability to identify a condition correctly. In this case, is a thief tampering with a car. The specificity is the test's ability to exclude a condition correctly. In this case, the noise of motorcycles on the road. Let's look at this graphically by making something called a receiver operating curve, or an ROC curve. On the x-axis is the vibration strength that a condition causes. On the y-axis is the frequency of the alarm going off. So again, this blue bell curve represents a condition, and that is a thief tampering with the door to unlock the door. The next curve represents another condition that can cause the alarm to go off, but in this case, it's the motorcycle noise. Remember, the sound of a motorcycle causes the car to shake less than someone actually shaking the car, okay? And so this black line is set at the 50-50 mark between the two conditions, just like the sensitivity specificity dial at the top of the screen. So what Matt first did when he installed this alarm is he turned the sensitivity way, way up because he didn't want his car getting stolen. This makes sense. You can see that we capture all of the small vibrations that would be a thief trying to steal the car. The problem with that, however, is that we also capture some of this mixed area. We're capturing a lot of motorcycle noise. And so the alarm is going to be going off a lot when the car is not being stolen. So the other extreme is if we turn that dial way, way down on the sensitivity, which suggests that the specificity goes up, way, way up in this example, but not necessarily directly inversely proportional for other medical tests. So now, Matt's alarm will not pick up any motorcycle noise at all. It will not go off for a motorcycle. But the problem, again, is that we're missing a whole lot of the thief shaking the car. So what is the correct answer? Do we want something with a lot of sensitivity, or do we want something with a lot of specificity? And the truth of the matter is, at least when it comes to medical tests, we get a little bit of both. A perfect test would, of course, be 100% sensitive and 100% specific, but that's impossible. So we get a little bit of each for every test that we do. Let's next talk about two separate tests that you might think about if you suspect one of your patients has colon cancer, or if you just want to rule out colon cancer. Now, this is by no means everything that you would do if you suspected colon cancer. That deserves a lecture all to itself. But I'm just using this as an example to talk about sensitivity and specificity. First is the test on the left. This is a fecal occult blood test. And it works basically by getting a smear of stool on your gloved finger, very important step, and then smearing that on the back of the card, and then putting some reagent, which is hydrogen peroxide, on the other side of the card, which reacts with the heme in the blood and causes a color change. So it gives you either a positive or a negative. In this case, what you see on the left is a positive test. It changed blue. The image on the right is a picture of an endoscope, which is basically a camera on the end of a long tube that allows you to explore the colon so that you could visually confirm or reject a case of colon cancer by directly visualizing the colon. The problem with endoscopy is that it's not readily available. If a patient comes into his family medicine physician and the family medicine physician is concerned about a possible polyp or a bleed or colon cancer, that primary care physician probably isn't going to have an endoscope and probably isn't going to be trained in it. However, the test on the left, the fecal occult blood test, is easy and quick to do and cheap. What does that physician do with the results? What if the fecal occult blood test says negative? How do you interpret that? What if it's positive? How do you interpret that? I mean, is a little bit of blood okay? Is a lot of blood okay? Are there other things other than colon cancer that could cause some bleeding? Sure. And these are things you have to think about. How sensitive and specific is the fecal occult blood test for detecting colon cancer? Well, that's the whole point of this lecture. Let's next draw out a contingency table and talk about it in the context of these two tests. Okay, so this is a contingency table. Keep in mind, these aren't official numbers. This is just an example. This table is going to help us answer the question of how well does a fecal occult blood test perform? How much do I trust the results? How sensitive is it? How specific is it as pertaining to patients with bowel cancer? On the top, we're using endoscopy as the gold standard, meaning that if the surgeon sees colon cancer on endoscopy, then the patient definitely has cancer. If the surgeon does not see cancer, the patient does not have cancer. In other words, just yes or no, does the disease exist in this patient? Another way to think about that is to imagine that the clinical test, or the horizontal rows, represent the alarm either going off or not going off. And if it goes off, we don't know why yet. It could be a motorcycle, or it could be a thief. We don't know yet. The disease, yes or no, which runs vertical, the columns, that's actually telling us yes or no, the car did get stolen or the car did not get stolen. It's the gold standard. The next important thing that you need to know is a couple of numbers. To work this table, you need to know how many people altogether were tested. In this case, there were 2,030 patients tested, all of which had a fecal occult blood test and an endoscopy. You could test any number of people, but you need to know that number, or you need to know how to figure out that number at least. So for all 2,030 people, we are going to do a fecal occult blood test, and we're going to confirm or reject those results based on the endoscopy. So first, out of the 2,030 people, our fecal occult blood test gave us 200 people that tested positive. It gave us 1,830 people that tested negative. In other words, the car alarm went off 200 times after something vibrated it, and the car alarm did not go off 1,830 times when something shook it. Then we did the endoscopy, or we confirmed if the car was or wasn't stolen, or if the disease was or wasn't there. And we found that only 30 people actually had colon cancer, and 2,000 people definitely did not have colon cancer. So you can see that these numbers aren't quite the same. Endoscopy is giving us different numbers than the fecal occult blood test, which is much cheaper and easier to administer. And again, just remember, in both cases, these numbers must add up to your total patient population, which is 2,030. If they don't, you made an error somewhere in your math. Okay? Next up, let's define a few terms. The first term to define is true positive. The true positives are those people diagnosed as being sick by the fecal occult blood test who are confirmed to be sick by endoscopy. Next is true negative. Those are people who were diagnosed as not having a sickness or not having this cancer and were confirmed as not having it by endoscopy. These are the two results where the fecal occult blood test was telling the truth or where it was being true. The people in the true positive cell truly were positive for the condition. The people in the true negative cell truly were negative for the condition. Does that make sense? The other two cells show us where the fecal occult blood test is lying. The false positive is that group that the fecal occult blood test said was positive when in fact it was not. The false negative is that group that the fecal occult blood test said was negative, but was actually, in fact, positive. Okay, and this comes back to the fact that no test is perfect. There is always going to be some inherent error in any given test. Here's something else that you have to understand with these numbers. The true positives plus the false negatives must add up to all of those people who were positive by endoscopy. Same thing goes for the other column. False positives and true negatives must add up to the total number of people who were negative by endoscopy. And again, horizontally it works too. This is important because tricky professors will subtract numbers from this box, but they'll ask you to calculate things like the specificity or sensitivity anyway. So you have to be able to fill in those blanks. Now on to the sensitivity and specificity and the positive and negative predictive values. Starting first with sensitivity. The sensitivity is that proportion or that percentage of sick people who are correctly identified as sick by the clinical test in question, in this case the fecal occult blood test. It is the ability of a test to detect a disease when there actually is a disease present. We calculate this number by dividing the true positives over the total number of those who had confirmed disease or who definitely have the disease. So in this case, it would be 20 divided by 30, which would give you about 67% if you round up. The specificity, on the other hand, is that proportion of healthy people who are correctly identified as healthy by the clinical test in question, the fecal occult blood test. It is the ability of a test to reject a disease when, in fact, that disease is not present. You would calculate this number by dividing the true negatives by the total number of people who definitely did not have the disease. So this would be 1,820 divided by 2,000, which would give you 91%. So what do we use them for? Well, sensitivity and specificity are used to help us rule out and rule in diseases. You've probably heard the mnemonics SNOUT and SPIN. Sensitivity, negative result, rules out. Specificity, positive result, rules in. Just remember the car alarm example if it doesn't make sense. A sensitive car alarm captures all of the thief noise, whereas a specific car alarm catches only the thief noise. So the difference is all versus only. So a very sensitive test with a negative result means that you can rule out the disease. A very specific test with a positive result means that you can rule in the disease. Okay? Generally, highly specific tests take longer, cost more money, and are harder to do, which means that you would perform a sensitive test first, catch a group of people who you think might be positive, and then run them through a specific test to pull out the few from that group who actually do have the disease. Does that make sense? You run a cheap test on a lot of people, make a group of those whom you think are positive, and then narrow that group down further with a specific test. Next up is positive predictive value. The positive predictive value is looking at the proportion of positive results that are truly positive. You calculate that number by dividing the true positives over the total number of positive fecal occult blood tests in this case. So that would be 20 divided by 200, or 10%. This is the probability that a person actually has the disease given a positive test result. For the negative predictive value, that is the proportion of negative results that are truly negative. And you calculate that number by dividing the true negatives over the total number of people that had a negative result on our clinical test that was in question, the fecal occult blood test. So that would be 1,820 divided by 1,830. That would give you a negative predictive value of 99.5%. So you could use those two values to talk with your patient in a way like this. Mr. Smith, I have the results of your fecal occult blood test here. They were positive. Oh my gosh, positive? That's terrible news. Should I call my family? Well, no, Mr. Smith, actually. The positive predictive value for this test is only 10%, meaning that there is actually only a 10% chance that you actually have the disease. We will need to do other tests to confirm. For the negative predictive value, it would be like this. Mr. Smith, the fecal occult blood test was negative. Well, are you sure? Do you think we should do some other tests? No, I don't think that will be necessary, Mr. Smith. This test has a negative predictive value of 99.5%. This means that there's only a 0.5% chance that these results were false negatives, or that you actually have the disease, despite the results being negative. Okay, does that make sense? So the sensitivity and specificity are looking at the ability of a clinical test to detect or reject a disease, whereas the predictive values are looking at the chance that a disease is or isn't there based on the results of the clinical test. Pretty cool, huh? You really need to get to the point in your personal understanding of these terms to where you don't need to stop and think about what each one of them means. So take a little bit of time and study this table until it makes sense. Now for a quick knowledge challenge. Let's see where you're at. What is the sensitivity of the following example? Well, if you recall, sensitivity is looking at the ability of a test to detect a disease when it definitely is there. So the sensitivity of this test would be 984 divided by 1,000, which would give you 98.4%. Let me add a number. Now, if you can, give me the specificity of this test. Trick question. You can't yet do that without the false positive number. Which calculation could you do, however? What about the negative predictive value? You can do that. The negative predictive value is the probability that your patient does not have the disease given a negative test result. And that would be 96 divided by 112, which would be 85.7%. Okay, so now here's the last number. Now tell me what the specificity is. And while you're at it, what the positive predictive value is. Remember, the specificity is the ability of a test to indicate no disease when in fact no disease is present. So that would be 96 divided by 100, or 96%. What about the positive predictive value? Well, the positive predictive value is the probability that a patient has the disease given a positive test result. So that would be 984 divided by 988, which gives you 99.6%. Lastly, would this test be better to rule a patient into a disease or to rule a patient out from a disease? Well, a lot of things go into that, but based on what we've talked about, and just looking at the numbers, nothing else, this test has a sensitivity of 98.4% and a specificity of 96.0%. So it has a better sensitivity. This test would be better to rule out a disease because there would only be a 1.6% chance that it would miss the diagnosis. Hey guys, this is Joel. Thanks for watching the lecture. I hope you liked it. I hope it helps you. Please leave me a comment. Let me know what you thought. You can also reach me on my Google Plus page, my Facebook page, or on Twitter. Please give me a like and subscribe. Thanks a lot. Good luck in school.